السلام عليكم ورحمة الله جميعا. شكرا لمنظمي الويبينار، وتحياتي لزملائي الأطباء في السودان وفي كل العالم العربي والعالم الإسلامي، ويعملون لحماية المرضى، وأتمنى من الله أن يشفي الجميع وأن يعم على بلاد المسلمين عامة الأمن والصحة والرخاء إن شاء الله. Thank you, Firas, for the nice case presentation. Also, thanks to Dr. Abdul Majid for the nice talk on heart failure, which covered part of my topic. Next slide. In my talk, I will go through the epidemiological review of the previous coronaviruses and the current coronavirus, the COVID-19, and I will mention the cardiac injuries in the previous viral outbreaks as well during the COVID-19, the pathogenesis of COVID-19, and what is the mechanism of cardiac injuries and myocarditis. And I will mention about the non-COVID-19, so the usual or the myocarditis. And I will go also through the COVID-19, although there is no more or no much changes between the non-COVID-19 myocarditis and COVID-19 myocarditis, except that COVID-19 is a very contagious disease and easy to be transmitted. Next slide, please. So the severe acute respiratory syndrome, or we call it SARS-CoV-2, which is the same as COVID-19. So in some literature or some references, you'll find SARS-CoV-2, or you can find COVID-19. It is the same. And why we call it SARS-CoV-2? Because it is the genome of the virus has similarities to the previous SARS, and almost 89% similar to the SARS. The COVID-19 is almost 89% similar to SARS, the previous SARS, and 50% similar to MERS-CoV, the Middle East. Mainly the COVID-19 will present as pneumonia, but can present also with cardiovascular complications and manifestations. Why cardiovascular and lung are involved in COVID-19? As mentioned yesterday and today by Dr. Abdul Majid, the angiotensin converting enzyme 2, ACE2 receptor is present in the lung and heart tissues. That's why both organs are involved in COVID-19. Next slide, please. So I will go to review the previous viruses and how it hit the world in the last 20 years. So the SARS was started in 2002 and affected almost more than 8,000 and led to 916 deaths, and 29 countries reported the SARS. The H1N1 was in 2009, and it hit the North America and China, and almost more than 50 million people were infected with the virus, and led to almost 500,000 deaths, and 168 countries were involved. The MERS-CoV, which was in 2012, and affected 27 countries and around 800 deaths. Next slide, please. The COVID-19, just go briefly about the story of COVID-19, which was reported in late 2019 in December in Wuhan, in the market. So first cases were reported, like 53 cluster of unexplained pneumonia, and then the authorities, the health authorities, started to search for the cause, And in January 9th of this year, so they discovered the genome of the virus, which is COVID-19, or we call it SARS-CoV-2. And as I mentioned in the previous slide, it's similar to first SARS-CoV in 2002. Both of these viruses will use the ACE2 receptors to get into the host cells. And as of today, more than 2.3 million affected worldwide, and it's increasing hour by hour. And unfortunately, it led to a lot of deaths. Next slide, please. This is a mechanism. It's mentioned yesterday, but again, just for the fellows, they can get through this slide. And you can see that the virus will go to the through the aerosol transmission or touching the contact. And this virus then will use the ACE receptors, ACE2 receptors, to get in to the host cells. Then the virus will replicate and will affect the humoral and cellular immunity with secretions of mediators and leading to the inflammatory response. Next slide, please. Still, there is no clear reason for the cardiac injury in COVID-19. It's still under search, and the putative mechanism. So it's still putative. There is no definite mechanism, but thousands of researches are running, and soon we'll get floods of researches. Hopefully, we can cope everything. So the first mechanism, putative, is through the ACE2 mediated direct damage to the lung and to the heart. Or COVID-19 can cause severe pneumonia, ARDS, and leading to severe hypoxia. And this hypoxia, if not treated, can lead to type 2 MI. Also, there is postulation or mechanism of cardiac microvascular damage. Another mechanism also is the plaque rupture. So in patients with predisposed plaque in the cardiac vessels can lead to plaque ruptures and lead to either MI or cardiac injuries. And the other mechanism is the cytokine response or systemic inflammatory response system. So in severe inflammation of the lungs, and if the patient is severely hypotensive, this can also affect the heart. No direct effect on the heart, but it is functionally affecting the heart, leading to cardiac injury. Next slide, please. So let us go to the myocarditis definition. So myocarditis, it's defined recently in 1995. So by the WHO, the final. So because it started from the 19th century, it started as dilated cardiomyopathy, but the final definition is an inflammatory disease of the heart muscle cells and is pathologically identified by conventional histology and immunohistochemical techniques, adding infiltration of mononuclear cells to the myocardium. So what is this? So it is an inflammation of the heart, but it should be confirmed by histological. So histological, we will go with the Dallas criteria if we can find an inflammatory infiltrates in the biopsy. So we should get a biopsy. So if we can find inflammatory cells along with degeneration or necrosis of myocytes, this is the histological, or immunohistochemical. This is by finding the T lymphocytes certain numbers criteria So if we can find more than 14 cells, including at least 3 monocytes plus at least 7 T lymphocytes with CD3 positive, so the diagnosis will be confirmed. So the clinical presentation of patients with acute myocarditis varies. So it ranges from subclinical or mild symptoms to leading to fulminant heart failure and cardiogenic shock. Next slide, please. So you can, for myocarditis, you can go to very nice 2 articles. One, just current state of knowledge and etiology of myocarditis, which is in European Society of Cardiology. Next slide. And the other one will be available also in the circulation, which is by the American Heart Association. So the fellows, you can go to these 2 articles. It will cover everything about the myocarditis. Next, please. So what are the clinical manifestations of acute myocarditis? And this table is from the European Society of Cardiology. So myocarditis can be caused either by infections or immune-mediated myocarditis, or it can be due to toxins. The infectious can be bacterial, fungal, protozoal, parasitic, like in Chagas disease. And here I will mention, because our talk is COVID-19, so it can be caused by the viral infection. And the most common virus infection, or the virus involved in myocarditis or causing myocarditis, is Coxsackie A and B. And most of the animal clinical trials were in Coxsackie B virus infection. And other viruses can cause, like influenza viruses, the mumps, Epstein-Barr virus, herpes simplex, herpes zoster, varicella, all viruses can cause, including, even there are reported cases of MERS, COVID, and SARS, and now we have a few cases reported by the COVID-19. Next slide, please. This is the pathogenesis. So the pathogenesis based on the endomyocardial biopsy is into 3 phases. I will not go in detail of this slide because it's very complicated maybe for fellows, but we have 3, phase 1, phase 2, and phase 3. Either it's caused by viruses or other. And in phase 2, you can find that there is no any virus PCR reported in the endomyocardial biopsy. Next slide, please. In COVID-19 patients with severe pneumonia and positive troponin, so if you find a patient with chest pain, for example, and with positive enzymes, is it really, especially now in the era of COVID-19, is it really myocarditis or another diagnosis? So we should know the differential diagnosis or causes of troponin leak, and I will leave this part to next slide, next presentation by our colleague, Dr. Ihab.
I think, sorry to interrupt you, Dr. Mohamed. I think we unable to get in touch with Dr. Ihab till now, so we're hoping to get in touch with him, but yeah.
Okay, so just I will mention it, the differential diagnosis of positive troponin, it could be due to acute coronary syndrome, basically either ST elevation, MI, or an MST, or it could be due to severe sepsis, especially in COVID-19. If you get, as we mentioned in the first slides, that severe hypoxia can lead to increased oxygen demand and leading to type 2 MI. So there will be imbalance between the supply and consumption. Other causes could be also due to renal failure. Sometimes also we can get troponin in patients with myocarditis. It could be also due to pulmonary embolism. Especially now we have reported cases of thromboembolization. So all these possibilities are there. So these are differential diagnoses. So we have to take one by one. Next slide, please. So the clinical presentation of myocarditis, usually the patient will present with acute chest pain. And usually it is a pericarditic chest pain. And if you allow me to talk in Arabic, because we have now a lot of people following us in the Facebook, and they are nurses or non-medical. فأي مريض يشعر بآلام في الصدر في أي وقت في أيام الكورونا أو غير أيام الكورونا لازم يمشي لأقرب مركز صحي أو مستشفى للتأكد من سبب الآلام. ممكن الآلام تكون نتيجة من شرايين أو جلطة في القلب، أو تكون نتيجة من التهاب عضلة القلب أو أسباب ثانية. So the chest pain is characteristic, is sharp pain, is pericarditic, and usually it is of new onset, either days up to 3 months in the acute, or in subacute, more than 3 months you can get history of chest pain. So this is a clinical presentation. Also the clinical presentation, the patient can present with palpitation, which is due to arrhythmia, as Dr. Firas mentioned. So patients with myocarditis, as we are going to see later, they can present with either palpitation or syncope, or even cardiac arrest. So this is the clinical. Then we go to the diagnostic criteria. In diagnostic criteria, we have 4 things. We have the ECG, we have the cardiac enzymes, we have the echo or CMR, and number 4, we have tissue characterization by the cardiac MRI. The ECG you can get mainly, usually we get, if there is pericardial involvement, so you get ST elevation. So if you get ST elevation with chest pain, most probably this is either STEMI or myocarditis. That's why what Firas and all centers are doing, any patient with chest pain and ST elevation, first of think we have to rule out coronary artery disease. That's why they took the patient, and it was the right decision, despite the contagiousness of the disease, of the virus and the easy transmission. So they took the patient and they took the risk, and they used the protection, personal protection equipments, and they took the patient to the cath lab and they ruled out the coronary artery disease. So this is usually the first step we do in cases of myocarditis. Or the patient will have a non-specific ST wave changes, either T wave inversion or widening of the QRS complex. Sometimes we get even heart block. So you can get any degree of heart block, first degree, second degree, or third degree heart block. The second thing in the diagnostic is the evidence of injury, which is a cardiac biomarkers, troponin. So elevated troponins indicates myocarditis. If you get a patient with ST elevation and suspected myopericarditis, usually with negative troponin, so we call it pericarditis. If we have ST elevation with positive enzymes, chest pain, and ruled out coronary disease, we call it myopericarditis. Number 3, the functional assessment by echo or by cardiac MRI. So by echo, if we can usually find regional wall motion abnormalities, and in most cases, it is confined to the inferior leads. We don't know, maybe because of the gravity issues. And you can find global hypokinesis. Sometimes you get normal heart or normal regional wall, no regional wall motion abnormalities, but do serial echoes using precautions. And during, as Dr. Majid mentioned, during COVID-19, we use limited echo studies. So we don't want the healthcare workers to subject themselves long. So we don't do full echo of 1 hour or 50 minutes detailed echo. So during COVID-19, even in most of the hospitals, including our center, we use limited study echo. The last thing in the diagnostic criteria is the tissue characterization by the MRI. So we can get either edema or we can get classical late gadolinium enhancement. If you do cardiac MRI and it is negative and still the clinical suspicion of myocarditis is there, the guidelines said we have to repeat it after 3 days because early sometimes you might not get these changes. So if we get at least one clinical presentation plus one diagnostic criteria, then we can say this is clinically suspected myocarditis. We don't say confirmed myocarditis. We don't say it is definitely myocarditis. It is still clinically suspected myocarditis. The more you get from the clinical presentation and from the diagnostic, we can say it is highly. For example, if I get chest pain with ST elevation or troponin leak, plus echo with regional wall motion or abnormal ejection fraction, and cardiac MRI is showing late gadolinium enhancement, here we can say it is very highly suspected myocarditis. And the confirmation is only by endomyocardial biopsy, as mentioned in the definition of the myocarditis. Next slide, please. So how the previous viruses affect the heart. So in the in SARS era, the Chinese healthcare authorities, they have like 3 clinical trials, and by Yu et al, he had a lot of publications. The patients were mainly affected by getting hypotension, tachycardia, brady, and most of the events were transient and there were no fatalities. But Pan et al, he had one case of cardiac arrest secondary to cardiac injury. MERS-CoV by Dr. Harabi and also Dr. Al-Habbani, they reported few cases of acute myocarditis and acute onset heart failure. And most of these patients, they recovered. Up to now, the clinical trials are evolving and the data is evolving in COVID-19. And we have a few reported cases here and there, and most of the cases are anecdotes. But in general, very few myocarditis are reported, maybe 4 or 5 cases. Maybe there are more cases, but they were not published in the literature. The main cases were from Wuhan in the first month in February. So they had like 138 total cases, and they got like 7.2% cardiac manifestations. And initially they mentioned mainly it is myocarditis, but none of these patients had any confirmation by endomyocardial biopsy. And most of the cardiac involvement or patients with cardiac injury, they ended up with intensive care, and the mortality was high among cardiac patients. Next slide, please. So what is the impact of COVID-19 on the cardiovascular patient? So here, because here we are cardiologists and we are concerned about our patients. So the data regarding cardiovascular involvement to COVID-19 is less described. And still, as I mentioned, it's evolving. We might get more data in the coming weeks or months. Clinically suspected, not biopsy-proven cases of myocarditis are only like 3. And one of these 3 cases, surprisingly, had endomyocardial biopsy and showed no criteria or immunohistochemical criteria. Also, The reported cases of myocarditis mainly in young patients. So it is worth to mention this again. So myocarditis in COVID-19 was shown mainly in young patients. As you see, first patient, his case, the patient was 29 years old, and 3 cases in China and Italy, all of them were young. And it is rarely affecting elderly patients. The published and anecdotal reports indicate cases of acute onset heart failure. Also, we have 18 case series published in New England Journal of Medicine, and scattered cases of myocarditis. Next slide, please. The cardiac complications of COVID-19 are approximately commensurate with SARS. So it is almost, or to some extent, similar to SARS and MERS, and there is no difference in the presentation. The main difference in the presentation is the severe pneumonia and severe ARDS more than the other viruses. So in COVID-19, we have more aggressive, and the transmission is very rapid. We don't know why. So the cardiologist should be prepared to assist other clinical specialties in managing cardiac complications. So usually cardiac or COVID-19 patients either will be admitted in critical care areas if they are sick and they are requiring hemodynamic and mechanical support. So usually we admit these patients in the critical care areas, or we have special isolated wards for stable patients. So cardiologists should be ready to help in seeing cardiac patients in other wards. To mention that, and thank you to colleagues in UK. So most of the physicians now, they are working in the front line, whatever the specialty is. So you can find endocrinologists, you can find cardiologists or surgeons. وهنا نترحم على أرواح زملائنا الدكتور عادل الطيار والدكتور أمجد، وربنا يتولاهم برحمته، وزميلنا EMS. They lost their life saving patients' life. So we admit these patients in critical care areas or isolated areas for COVID-19 because of transmission to other vessels. Critical care and cardiology team should confer to guide care for patients requiring extracorporeal circulation support or LVAD or Impella, as mentioned by Dr. Majid. So again, for the fellows, we have 2 types of ECMO machine or ECMO settings. Actually, it is the same machine, but the setting is different. If we have primary hypoxia issues without hemodynamic problem, so we use the oxygenation or artificial lung, which is through VV ECMO. So we take the venous blood, we take it to the machine, and we oxygenate the blood, and we get it back to the patient. But the other type of ECMO, which is veno-arterial ECMO, so we take the blood from the venous, we'll go to the machine, and then this blood will be pumped into the systemic artery. So this is the idea of ECMO. So for support in ICUs, in ARDS patient, sometimes the ICU, they put the ECMO machine in the ICU for the VV ECMO, and it's managed mainly by the general ICU. But the veno-arterial, it can be with ICU and the cardiac intensive care. Some patients might need left ventricular assist device if it is pure left ventricular problem, or by that, or Impella. Patients who demonstrate heart failure, arrhythmia, ECG changes, or cardiomegaly, all these patients should have echocardiography. and echocardiogram to assess the heart. Next slide, please. So we have to make plan for quickly identifying and isolating cardiovascular patients with COVID-19 from other patients. Why we take care of cardiovascular patients? As now we see in the literature, most of the mortalities and the poor outcome and the negative predictive things were in the patients above 65, patients with underlying cardiovascular disease, patients with diabetes, hypertension, or stroke. So these patients, they do worse with COVID-19. So we should not mix things. Every patient can get COVID-19, whether cardiac patients or non-COVID or non-cardiac patients. But the COVID-19 manifestations and inflammatory response is mainly in this group of high-risk patients, elderly, cardiovascular patients, and hypertensive patients. It is reasonable to advise all cardiovascular patients of the potential increased risk and to encourage additional reasonable precautions in accordance with the infection control or CDC guidance. Next slide, please. Again, I will reiterate the importance of wearing personal protection equipments and the healthcare workers protection. So we are working with these patients, so we should be very careful not to play with this and not to underestimate. So we should be very meticulous in putting the PPEs so as not to transmit the disease to the community and to our family and our colleagues. Good history from the patient if the patient is not intubated, because as we mentioned, history taking, especially in myocarditis, we can differentiate between the chest pain of myocarditis and the chest pain of MI from the history. Next slide, please. So the COVID-19 implications for patients with underlying cardiovascular disease. So if we have patients with cardiovascular, so the most important thing is the psychological support of these patients. Now we have problem with because of the news, the mortality, and these things. So when patients with COVID-19, they tested positive, they have a lot of psychological insults. So psychological support by the psychoanalyst or social workers is very important. And if the patient is admitted, usually they are isolated in the hospital, in rooms and ICU, and their family, they are away from them, and to find some way of communication between the patients and the family. So we can use either WhatsApp, video calls, or Zoom videos between the family and the patient. It is important for patients with COVID-19 to remain current with vaccination. So still there is no vaccine for COVID-19, but cardiovascular patients who are at risk, they should get vaccination for influenza and pneumococcal vaccine to protect them from secondary infections, other infections. So cardiovascular patients should get vaccinations as their American College of Cardiology, American Heart Association, and European Society of Cardiology guidelines. It is reasonable to triage COVID-19 patients also according to the underlying cardiovascular. So patients with cardiovascular, as I mentioned, diabetic and elderly patients, they are more prone to get severe disease. Next slide, please. So what diagnostic test we use for myocarditis, either in COVID-19 or non-COVID-19? So we should do CBC to see the white cell count, the lymphocyte count, because we know that we have lymphopenia with COVID-19 patients. Platelet counts also is very important. Inflammatory markers, ESR, C-reactive protein, interleukin 6. And it's interleukin 6, especially if we have cytokine storm, it's very important to do baseline interleukin 6 assessment, and later on with the progress of the disease, we should do another test. Some reported cases of myocarditis, they used interleukin baseline and after recovery. So there was a decrease, significant decrease. And the case reported from Wuhan, the baseline was during the storm of the disease, it was 276. And after follow-up, it went down to 27 only. Also, ferritin is very important, one of the inflammatory markers, and high ferritin sometimes indicates poor prognosis. LDH is very important, D-dimer, and we don't forget also the lactic acid. If we have high lactic acid, it means we have more tissue hypoperfusion. We should do also troponin, CKND, and BNP. So troponin, you can use whatever available in your institute, either high sensitive troponin or the regular troponin. Viral screening. So we should do all viral workup, including COVID-19. We should do all panels, all types of corona, MERS-CoV, SARS, H1N1, all herpes. So the bundle of viral screening should be done for every patient. And one of the patients, or few of patients with myocarditis during COVID-19, they were tested for COVID-19, they were negative for COVID-19, and we found another virus causing, so they came together with patients of COVID-19. So we should also increase our yield for viral screening. Serum cardiac autoantibodies, also important to rule out autoimmune diseases. ECG and echocardiography, as we mentioned. We should, every patient with myocarditis, or most of them, we should rule out coronary artery disease, either by coronary angiography, invasively, or by doing cardiac CT. Suspected patients with myocarditis, they should get tissue characterization by the cardiac MRI, if it is feasible, and if the patient is stable, to be transmitted to the cardiac MRI. And if possible, and the patient is, if the patient is young and diagnosis is not clear, we can go up to endomyocardial biopsy. Here to mention also, for the ECG machine, we should keep one ECG machine in the ICU COVID area or COVID areas, if the facility is there. So if we have more equipments, so we can keep one machine there. Also, we can keep one echo machine. We don't mix this machine with non-COVID-19 patients. So we don't transport these machines from one area in the hospital to another area. It can transmit the disease easy. Also, the cath lab, if there are more than one lab in the hospital, so like in our center, we have 4 or 5 labs. So we use one lab for COVID-19 suspected or confirmed cases. Next slide, please. What's the prognosis in myocarditis general? And because still we don't have, as I mentioned, we don't have enough data for the COVID-19 to tell the prognosis. Most of the reported cases, fortunately, they recover. The 3 or 4 cases mentioned in the literature, they recover. But they pass through very critical illness, and some of these patients, they got mechanical support devices, and alhamdulillah, they recovered. So in general, in myocarditis, 50 patients can recover in 2 to 4 weeks. While the 1/4 of patients, they can get permanent cardiac dysfunction, so dilated cardiomyopathy. And in 12 to 25% of cases, we can get acute deterioration leading to severe cardiogenic shock and dilated cardiomyopathy. Next slide, please. What is the management of myocarditis or myocarditis in COVID-19? And here, just figure the healthcare workers are fighting to make this virus more benign. Hopefully more research will come soon, so we'll get good vaccinations and good treatment. Next slide. So the treatment differs if we have a stable patient, so we admit the patient in the general ward or CCU, but if the patient is critically ill, so we admit this patient in the CCU or cardiac ICU according to the setups. Still, no, even in myocarditis, no large randomized control trials. Even in the myocarditis, again, I mentioned, we don't have large control trials, and there is no clear guidelines. And most of the published guidelines, these are based on expert opinions. So in acute fulminant myocarditis with cardiogenic shock, so we admit this patient to the ICUs. So we use inotropic support. And if the patient is having severe ARDS with COVID-19, which is the usual scenario, the best inotropic or pressure support is the norepinephrine #1. If there is no improvement on norepinephrine and there is severe cardiogenic shock, we can add dobutamine. If still the patient is in severe shock, we go to epinephrine or vasopressin. So we go as in the severe COVID-19 infection. If the patient is having COVID-19 severe pneumonia along with myocarditis, here we can also, if the patient is on high inotropic support, here we can add steroids to support the hemodynamics and as in surviving sepsis campaign guidelines. If the patient is in severe hypoxia, we go to mechanical ventilation. If the patient is mildly diseased, like what, thanks to Dr. Ala, he mentioned yesterday, the mechanical ventilation and treatment of hypoxia in COVID-19 patients. If the patient is not severely hypoxic and early stage, you can use non-invasive ventilation, either CPAP or BiPAP, or high flow nasal cannula in mild cases. We don't intubate every patient. If you need to intubate every COVID-19 severe pneumonia, you cannot cover all these patients. So if the patient is hypoxic and still not responding to oxygen therapy by either conventional mask or by advanced non-invasive, then we have to intubate and connect the patient to the mechanical ventilation. And we use the same protocols for COVID-19 patients. We don't go with high PEEP unless needed. Early proning also is suggested in COVID-19 patients. We go with ARDS protocol, like low tidal volume. So Dr. Ala covered everything. And if the patient is still critically ill, we can go to mechanical support either by ECMO, Impella, or ventricular assist device. And here we have to triage. And Dr. Abdelmajid, he answered the question nicely. Do we need to take every patient with severe cardiac injury and COVID-19 for ECMO or that? No, we should triage. We should select those patients who can benefit from these procedures, and if the outcome is favorable. Next slide, please. In stable patients, we advise for complete bed rest. every patient with myocarditis, he should be confined to bed. So any activities is not allowed, and even the football players or those who are doing a lot of exercise. So we advise these patients not to get exercise for at least 6 months. No exercise. We can use diuretics if the patient is in heart failure, and we use the same way. If the patient is mildly congested, we can use oral. If the patient is severely congested, we can use either IV boluses or infusion. There's no difference between either infusion or boluses. Beta blockers can be given if the patient is not wet. So if the patient is NIHA class 4, so we don't start beta blockers. If the patient is already on beta blockers and it is hemodynamically stable, we carry on beta blockers. AS, ARBs, yes or no? Dr. Majid answered this question, and our colleagues also yesterday, they covered this part. So we can use ACE inhibitors, we can use angiotensin receptor blockers, we can use also cyclopetrine, neprilysin, the Entresto. So we should use. Why? If the patient is already on, if the patient is needing these medications, we can start because there is upregulation. There is problem with ACE, as mentioned by Dr. Abdul Majid. So we encourage all patients to take these medications. There is no still contraindication, but we'll see in the future, nearest future, the final answer. But meanwhile, we should either start or keep the patient on these medications if he's already on. Also good to start also patient on potassium sparing agents like aldactone if there is no contraindication, if there is no renal failure, if the creatinine clearance is more than 30 and the potassium is not high, so we can start this patient on potassium sparing agents, especially myocarditis with depressed LV function. If the patient is coming with pure myocarditis, no role for non-steroidal anti-inflammatory drugs, especially if the patient is very sick and in ICU and in heart failure. So we should avoid non-steroidal anti-inflammatory drugs in pure myocarditis. But if the patient is having combination of myopericarditis or pure pericarditis, we can use non-steroidal anti-inflammatory drugs. Next slide, please. Arrhythmia treatment is very important. And as mentioned yesterday by our colleagues and today by Dr. Firas, arrhythmia can happen in patients with COVID-19, especially those patients with myocardial injury, either myocarditis or depressed LV function from the cytokine storm. These patients are liable to have arrhythmias. So we should treat arrhythmias as non-COVID-19 patients. We should select the antiarrhythmic medications according to the type of arrhythmia and according to the hemodynamics of the patient. No approved antivirals yet for COVID-19 myopericarditis. Again, I will repeat, no approved antivirals for acute myocarditis in COVID-19 patients. Still, centers are using antivirals for COVID-19, but not for specifically for viral COVID-19 patients. Still, data is evolving, and we'll see in the coming future. In cases of stable COVID-19, so if there is no severe ARDS, acute respiratory distress syndrome, if the patient is not having severe pneumonia and not hypotensive with low blood pressure and hemodynamic and unstable, we should avoid the steroids. But if the patient is manifesting the myocarditis along with severe hypotension and multi-system or multi-organ failure, so we should use stress dose of steroids, and the usual dose is hydrocortisone 100 milligram IV stat, then followed by hydrocortisone 6 hourly. This is the usual guidelines by the Surviving Sepsis Campaign, and the most of the institutes using the same protocol for the COVID-19 patients with severe pneumonia. Patients with myocarditis after recovery, they need long-term follow-up, especially if the ejection fraction or systolic function didn't recover within the hospital stay. So we should follow these patients in high-risk clinics, and as in our center and Dr. Abdul Majid mentioned, we have a special cardiovascular disease management program, heart failure clinic. So we follow these patients in heart failure clinics, and we continue these patients even upon discharge on if the ejection fraction is affected. So we keep these patients on beta blockers, ACE or ARBs, and we follow the ejection fraction after discharge, and even we do cardiac MRI follow-up as outpatient setting. Next slide, please. Still, there is no clear, so every institute is different from another, every country is different. Still, there is no clear guidelines for the management of COVID-19. But here I will show this diagram showed in the European Society presentation of myocarditis, and this one was proposal by Journal of Heart and Lung Transplant, and this one was published this March. So we divide the scenario and the presentation into 3 stages: stage 1, stage 2, and stage 3. Stage 1, this is an early infection. Usually, it is patient will be manifested by high temperature, dry cough, diarrhea, fatigability. So this is the first stage. Second stage, this is usually the pulmonary stage, and these patients usually they will manifest shortness of breath, and they will present with hypoxia. And the third stage, which is the due to the systemic inflammatory response and cytokine surge, we call it host inflammatory response phase, or phase 3. And usually these patients will manifest as ARDS, shock, and cardiogenic shock. So the proposal of this organization, they used remdesivir, which is emerging drug, and there are a lot of promising, inshallah, clinical trials on this drug, and inshallah we'll get good results. And centers are using chloroquine or hydroxychloroquine with convalescent plasma transfusions. This is in all stages. But in the third and second stage, here we can add corticosteroids or human immunoglobulin medications, or interleukin 6 or 2 inhibitors. Next slide. So take home message: data is evolving in COVID-19. There is no evidence-based treatment for COVID-19 complications. Need for more randomized controlled trials. Myocarditis is not a proven complication of COVID-19. Still few cases reported. We might get more cases, hopefully no. The diagnosis of myocarditis and its cause is based on endomyocardial biopsy, if it is feasible to confirm the diagnosis. The diagnosis is not clear. High troponin does not equate to myocarditis or MI in COVID-19. It could be due to myocardial injury or type 2 MI, as I mentioned. Next slide. Hopefully, we'll get rid of this virus. Again, we reiterate and advise all to get the precautions: hand hygiene, hand hygiene, hand hygiene, hand hygiene, hand hygiene, and PPEs. وأنصح الجميع المرضى وغير المرضى والأصحاء وكل الأهل وكل الأصدقاء باستخدام غسل اليدين بالكحول أو بالصابون، واستخدام الواقيات وتجنب الازدحام، والالتزام بالتعليمات السلطات المحلية بحظر التجول والجلوس في البيت. Stay at home. Thank you very much.